Good evening, everyone. Thank you again for joining us tonight on another of our Euclid Systems Corporation webinars. We're pleased to have people listening in tonight from across the US, Canada, Latin, South America, Asia, and I think even a few Europeans are joining us today. So my name is Jane Beeman, and I'm here to coordinate things for us tonight. I am the Global Director of Professional Relations for Euclid Systems. So I'm going to begin tonight, as I always do, to tell those of you who are not familiar with Euclid a little bit about the company, and then you'll join us for an exciting webinar with Dr. Michael Lipson, who's going to help us with this unusual time. What does back to school mean this year? And in what back to school means for us as practitioners and for those of you who are parents, what do we do to help our patients understand that myopia management is an important process that cannot be held off because of concerns? So let's talk a little bit about Euclid. Now, Euclid is a company that's been in the orthokeratology business for over 25 years now. Euclid was the first company to get approval in China and Japan and Taiwan to be importing Ortho-K lenses into those countries, and is still one of the leading companies in Asia today. We haven't been as visible in the US, even though we're a US-based company, but we've been changing that over the last few years, and I hope those of you in the US, if you haven't heard of Euclid, you'll spend a little time and research us. We were one of the first companies to get FDA approval for orthokeratology for the overnight temporary reduction of myopia in children, and we continue to focus wholly on that particular part of the business. Now, I do have to start this evening by reminding you this presentation expresses the opinion and the use of these contact lens products as utilized by those of you here, licensed eye care doctors. It may not reflect the FDA definition for orthokeratology or even the specifically approved use of Euclid products. Now, let me start by introducing tonight's speaker. Dr. Lipson has been involved in orthokeratology in its various forms since the mid-1970s. He was an associate professor at the University of Michigan. His clinical practice for many years has focused on specialty contact lenses, including orthokeratology, keratoconus, postcorneal transplants, post-refractive surgery, and severe dry eye patient. He's published many peer-reviewed clinical research studies on Ortho-K and vision-related quality of life, myopia management, and various new lens design. He lectures around the world on specialty lenses and other research topics, and is an independent consultant to the specialty contact lens industry. Dr. Lipson is also a fellow in the American Academy of Optometry and the Scleral Lens Education Society. He's on the GPLI advisory board, has served as vice president in the Scleral Lens Education Society, and has been on its board for many years. So I hope you can help me tonight in welcoming Dr. Lipson and his presentation. Thank you again.
Well, thank you, Jane. Thank you for that warm welcome. And I hope everybody can hear me, and greetings from around the world, and the United States, as Jane said. But tonight, I'm kind of excited to talk to you about the opportunities that we have now going back to school in this very, very weird COVID affected world. And basically, we're going to talk about myopia management and basically how Ortho-K fits into that. But this is probably a little bit of what back to school will look like, if not a lot of it. Back to school will be back to the kitchen and the dining room tables, with parents overseeing assignments sent home via the internet to their students. So again, kids are going to be home a lot. They're going to be working just as much up close and maybe more on their computers than they have been, and on their digital devices. Now, what you are going to see in your offices, basically, you've already seen it probably if you've gone back to work. You're seeing things that you have to do to keep your staff safe and yourself safe, and the procedures that you have to do to really keep things confident for your patients and safe for everybody involved. Now, when your patient walks into your office, this is what they're seeing is you, but they may not recognize you in the costumes that you have on and your PPE. So uh, essentially, this is a different experience for you, and it's certainly a little bit different for the patient themselves. So, but with that difference comes an opportunity to educate both parents and the patients about some of the new procedures that you have to take to keep them safe within the office and to keep them comfortable coming in. And so again, you've already implemented those, I'm sure, but the opportunities here also present themselves to present new treatments and new forms of managing myopia, and keeping the parents and the patients educated about that is the key to your future success. So the opportunities that are presented here, certainly, as I just mentioned, and education and letting patients know what is out there in terms of myopia management, in terms of the story of myopia, introducing new treatments that they may not have heard of. And certainly the biggest issue these days, everybody is concerned about safety and the health aspects of not only their general health, but their ocular health and the specifics that they may not have become aware of yet. And so they're looking to you to teach them how do they stay safe and continue to care for their vision and correct their vision. Discussing both the long and the short-term eye issues that come up for kids in terms of how well they are taking care of their eyes, what the implications are long-term, and really as an information source for all of your patients, you become an information source to be able to give them the newest and latest information that you've made yourself aware of here. And in doing so, you're going to create a very long-lasting and a closer relationship with your patients. So when you talk about the story of myopia, really begins with you getting everybody on board in your office, educating your staff as to what is going on and what is going on in the eye care field, all the new things, new procedures that are coming up. So certainly it starts on the phone. Now, if a patient calls and they ask about myopia management because it's out there in the media a little bit more, certainly your staff has to be able to field that question and be able to address it in a very educated way. If the patients do not ask about it, that's an opportunity for the staff to mention it. Something to the effect of, are you making an appointment for myopia management today? So again, it starts at the first contact with your office, and that person is the receptionist who answers the phone. At the reception desk where they greet the patient, same thing. They have to really be confident and aware of what you are doing to deal with myopia and how it is different than what has been happening in the past. Your techs have to be able to subtly work that in and be able to answer questions as the patient goes through their routine exam. And certainly in the exam room, you have the opportunity to mention it whenever patients ask a question. But at the end of the exam, as you're prescribing correction, you can explain essentially that there are new options available, not just for correcting myopia, but managing it. Having printed materials for them to take home is also very, very helpful. And we're going to actually expand on that a little bit later in the presentation. But I just mentioned the difference in myopia correction compared to myopia management. Now, say for example, at the end of your comprehensive exam, you say, okay, your son Sean, he is nearsighted and he needs to be able to see better in school. And you have to be able to explain the difference between what we have done in the past was just prescribing a pair of glasses or contact lenses to correct vision. And what we have learned from that if we just prescribe glasses for the patient, for example, correcting their vision, they see great, but we've learned that these kids progress in myopia faster than if we initiate some kind of management of their myopia, not just correction. We also have to tell them what we know about this in terms of if the child is nearsighted at this point, that statistics and studies are showing that they will progress at a fairly steady rate over their growth years and probably late teens and even into their early 20s. But we have to also emphasize that there are some things that although we have learned a lot, there are still some things we don't know about this. And we don't know exactly how fast that particular child will be progressing. We don't know the very, very best way to take care of them for each individual patient. But based on what we know, we're looking at each patient on an individual basis to be able to customize a plan of managing their myopia. So if we go into something that we do know from studies and from many, many investigative histories, that if you have, like the picture shows, two parents here who are both nearsighted, this is a patient who is at high risk for developing myopia if they're not already myopic. About 50% of those who have the kids who have both parents myopic will be myopic. If only one parent is myopic, they have a little less risk, about 33% chance. And even if both parents have good vision, they're not nearsighted, about 25% of the kids are going to develop nearsightedness now. And that's just the growth rate of myopia and some of the things that we're seeing in terms of how kids are using their eyes and how much time they're spending outside. And that brings us to the next point here, is that we know that kids who spend more time outside develop nearsightedness at a later date. It can delay the onset of nearsightedness. But again, most of the studies are showing that once nearsightedness is diagnosed and they become nearsighted, increased outdoor time may not have the same effect on that. So again, as questions come up on this, I think we're going to take questions at the very end of the presentation. So I think you can use the chat function on the Zoom meeting to write in questions that Jane will ask at the end of this meeting. Again, getting the kids outside before they're nearsighted about 2 hours a day could delay the onset of nearsightedness. The other thing we know, that if the child in your chair is myopic and they are 6 or 7 years old, they are going to progress, and they're going to progress at a faster rate than if you have an 11 or 12-year-old in your chair at that same level of myopia. So again, the rate of progression is faster in younger kids. So again, when we talk about risk of developing nearsightedness, this chart at the bottom has been shown to be quite predictive of predicting a risk of becoming nearsighted. So again, the example, you have a 6-year-old in your chair and they come in and the exam, you do a cycloplegic evaluation and they end up being plano. So at this point, many doctors in the past have said, you know, hey, your kid has great eyes. End of story, on to the next patient. Well, that's just the beginning of the story. Based on these findings, that 6-year-old who's plano is at very high risk for becoming nearsighted over the next few years. So essentially, that's where the opportunity lies for you to then start sharing the story of what we know about the increased prevalence and increased incidence of myopia and what is likely to happen for that child over the next year. And with that, you may say, well, because this child is at such high risk, being plano at age 6, you want to see them in 6 months. There's a few other things that you want to do, but again, that'll be later in this discussion. Same thing for an 8-year-old who ends up being even plus a quarter. That 8-year-old is still at risk for developing myopia. And if you have an 11-year-old who, again, comes out at even plano or minus a quarter, they're also at risk. So again, this is part of the opportunity to educate the parents on what we have learned about the track record of myopia, about increasing incidence, severity, the degree of myopia, and that it's going to progress. So again, when we talk about all these factors, then we have to go into the presentation of really, when we're talking about managing, what does that mean? Well, we have a number of studies that are supporting the increased incidence and prevalence of myopia. There's no doubt about it. Everybody probably on this call has read this. And every day you get in the emails, newsletters, journals, everywhere. It's everywhere now. We know that from these studies that myopia progresses very steadily and rapidly if they're going to continue to wear traditional spectacle correction. So again, this is our opportunity to explain that there are interventions that we can prescribe and that the patients can participate in that will slow that rate of progression. Those specifically being ORTHO-K, soft multifocals, and atropine. And with that, you may be able to say demonstrate something like this projecting in this graph on the lower left, which shows a 7-year-old at -2, and their normal rate of progression on average is shown in red. And so that by the time they're 18, this chart is cut off at 17, but by the time they're 18, they're going to be about a 7 diopter myope. And with ORTHO-K in this particular example, if they're at about a 50% reduction in their level, they're going to end up at -450 at that same 18-year-old age. Again, how important is that? We're going to talk about that in a moment, but it is significant. So just a quick summary of what we talked about up till now is that our role at this point is to educate the parent and the patient about what is in their future and what we have learned about myopia. Next, we want to inform them without scaring them, but giving them some realistic expectations of what the studies are showing and inform them of what these various options are, the ORTHO-K, the soft multifocals, and atropine, and the advantages and disadvantages of each one of those. And the follow-up on that is to really prescribe for that patient on an individual basis. As you look over everything, you talk to the parents and the patient, and you prescribe what you would do for your child. You look at that kid as if they were yours. How would you deal with that? Now, there are numerous studies out there, like I said, and in terms of the severity of high myopia and the implications, one of the most severe long-term complications is myopic maculopathy. And in evaluating different studies from all around the world, Mark Bullimore put together a pretty impressive paper documenting that each diopter of increased myopia is associated with a 67% increase in the prevalence of myopic maculopathy. Now, that's going up the graph. If you kind of look down the graph, reversing it, if you were able to slow myopia and the development and reduce it by 1 diopter, you're reducing their likelihood of developing this maculopathy by about 40%. And so what this also shows is that the benefit to reducing myopic progression is there, no matter what their level of myopia, whether they're at -2 or -10. No matter what level, if you can limit the myopic progression at all, you're providing a benefit to the patient. The benefits of that lower level of myopia, number one, as we just mentioned, is the reduced risk of really blinding type complications or vision impairment. But in addition to that, there is less visual disability if they don't wear their correction, meaning if they happen to walk around without their glasses, people who are less nearsighted are easier to function, can function at a better level. As a side note on that point, also it's been shown on some studies that even those who are corrected, they actually see better when they're lower in nearsightedness when they do have correction. And the last option that is actually benefit of lower myopia is that they do have better options and better outcomes if they elect to do surgical correction like LASIK. So as that patient is in your chair, if you look at the option of Ortho-K, for example, should you start it now? Should you wait? Well, it is on an individual basis. How you prescribe for that patient. Is the patient ready? Are the parents ready? But the younger that that patient is started, the better it's going to be long-term for them. At this point, when they're young, they're kind of listening to you better. So talk about compliance and how important it is and discuss safety with them. That's the number one concern of parents, and how important it is for the child to be compliant. But I think one of the most important things, if you're doing any kind of myopia management, is to measure axial length and create a growth chart. Meaning, when they go to their pediatrician for a checkup, you know they're going to stand up on the wall and they're going to get measured for height, and they're going to be measured, okay, you're at 50.2 inches this year. Okay, so essentially, next time they go in, they're looking at that chart, and the doctor's saying, well, looks like he grew 1.5 inches this year. Well, you can do the same thing with myopia. Besides the fact that you're checking them at the phoropter cycloplegic evaluation for their level of myopia, you can have a chart that you show the patient and say axial length last year was 23.89 and this year it's now 24.15. So they have grown, they have increased their axial length, and that is the potential issue later in life. So I think you can make it graphic for them and make it important and say that the length of their eye has changed and we want to slow that change down. And you've given them reasons why it's important to do that. So if they are considering contact lens correction of any type, whether it be Ortho-K, whether it be soft lenses, safety is the biggest concern of parents. So in general, right now, is it safe to wear contacts during COVID? Well, you can tell them, yes, it is. And you can point out how important the compliance and care and hand washing is. But if they need to hear it from other authorities, you have the American Optometric Association. You have a resource from the CDC, from Mayo Clinic, or even the NIH that has made a statement on the safety of wearing contact lenses during COVID. And the basic summary on all of these sites that you'll find is that, yes, it is safe to wear contact lenses, and that keeping your hands away from your eyes during the day is important, and washing your hands is the most important issue. If they're concerned about safety relative to Ortho-K, there are a couple really good studies on this. The biggest one that was done was showing that the risk of microbial keratitis was about 7.1 incidences of microbial keratitis for every 10,000 patient years of wear. That's a pretty small amount, and that also it's found that you can minimize those risks if kids are compliant in the follow-up, coming in for follow-up, and in terms of lens care and hygiene. Hygienic issues really critical. But again, you can show charts and documentation and all these studies that shows that Ortho-K does slow the progression of myopia, and it slows the rate of that increasing axial length, about 40 to 60%. The studies listed on the right are the 7 most cited and most, I guess, credible studies on this over the years, and you can see that they were done a number of years ago already, that it's between about 39 and 60%. And all of those, except one was a 2-year study, one was a 5-year study. So based on this information, an example that I like to use is that if you have an 8-year-old who's in the chair, never had glasses before, and they're showing a myop need of -1, it's likely that they're going to progress to about a -6 by the time they're 18. And with a 50% reduction at 18, they're going to be -350. So again, you can imagine the difference between somebody who is a -350 functioning without their glasses compared to somebody at a 6 diopter myope. So this is a graphic way of showing this to patients. Now, these studies are very, very important, and they're very telling for us and for the patients and for the parents especially. But I want to just make a note of caution that if you have any of these patients in your chair, as important as it might be and as good a candidate as they may be for myopia management, none of these cases will have been charted in any of those studies. And the reason is, in this first patient, their cylinder. Most of the studies that have been done limit the cylinder to 150 or below. But that doesn't mean you can't do this patient. It means that we don't have a study with this population in that. So again, this is a good candidate, but you have to say, we have to extrapolate what the individual response of that particular patient will be. This next one is 7.5 years old. Now he's changed from -75 a year ago to -2 now. So he's progressing, there's no doubt about it. But in the studies, most of the times they will start with 8-year-olds. Now, as we said before, all the other previous studies on myopia progression have shown that kids who are younger progress faster. So this is a great candidate for managing their myopia. But again, you can't go by the studies and say this kid is going to stop by 50%. He may be more. You have more of an effect on these lower myopes and on these kids. Even though they still may progress, the percentage of change is going to be more helpful for them. This last patient, 12-year-old female, is not a really high prescription, but because of the aniso that they have, the difference in the two eyes would exclude them from most of the studies that are being done. Also, you'll note that that patient wasn't correctable to 20/20, and those are also excluded from studies. But it doesn't mean you should not do some type of myopia management for them. They're still great candidates for this, but you can't base the predictions of what they will do based on the studies. So again, starting Ortho-K, I'd say the benefits of what we've presented so far outweigh the potential risks. Starting earlier, you reduce the risk of their long-term complications like retinal detachment and myopic maculopathy. Those are all related to that long length of the eye, the long axial length. So the earlier you start, the greater that your ultimate benefits are going to be, and the less the ultimate axial length and their overall endpoint refractive error will be. But in addition to providing those long-term benefits of safer and less risk of those serious eye problems later on in life, these patients have an immediate benefit. The short term is that while they're wearing these Ortho-K lenses, they get better vision-related quality of life. And that's what we're going to talk about in a few moments here. But so again, if you choose to start a patient in any kind of myopia management, particularly Ortho-K, you need to go through a really, really thorough, comprehensive exam to establish a baseline. So just like your regular exam, you're going to update your refraction, preferably in a cycloplegic form. You evaluate their binocular status, get a good topography, measure their axial length. And at the slit lamp, this next part is really critical. Again, establish if they have any baseline staining, scarring, neovascularization, any pigmentation, as well as the external, evaluating their lids, both the position of the upper and the lower lids, any blepharitis, ptosis, and any mal-directed lashes, myobomitis, pigmentation, scars, melanosis, all those things. And the reason that's so important is that the parents are looking at their kids while they're undergoing Ortho-K very, very carefully. And just, you really, no matter if you see these things and you don't mark them down, you will not have documentation, and the parents will inevitably blame whatever they're seeing on the Ortho-K. They never had this before. But again, preferably take a photo of these things so you can be able to document that these things are present before any Ortho-K or any other soft lens treatment is initiated. Have this documented is really critical, because like I said, if any of these things are noticed later on, again, you're going to be blamed for this. So have documentation. Of course, evaluate the fundus internally really, really carefully. You want a healthy eye before you start. And there are some special history notes, again, talking to them about their sleep patterns, if they are sleeping normal hours, if they get up in the middle of the night, other activities that they're involved in, all affect the treatment. So after you get the evaluation, you're ready to proceed with some kind of treatment, it's important to spell out every detail so that the patient knows what to expect. Again, you have the details of what the benefits and the risks of undergoing any of these procedures is. You put a big emphasis on the lens care and compliance, but provide details of the Ortho-K fitting and follow-up, all the procedures that are done, the number of follow-up visits, what is involved in follow-up care, and what the patients can expect from you in addition to what you are expecting from the patient. You expect them to be compliant, to listen to what you are saying and take your recommendations, but they got to know if they have a problem, they can come to you and what they can expect from your office. So there's a portion on this informed consent or fitting agreement that involves telling them exactly what they can do if they have any of these symptoms, if they lose a lens, whatever, if they're having dryness, if they're experiencing any issues, what's important for them to contact your office about. So setting expectations is really, really critical. Again, telling them about what they can expect about the improvements of their vision, that it's not going to necessarily be perfect after the first night, those kinds of things. Again, people form all kinds of opinions of what they've heard about this. So essentially spell it out for you and take any questions that they have immediately. Now, in your office during COVID, right now, you have to see these patients face to face for these baseline exams, for topography, for fitting, and for the instruction. Certainly to be able to evaluate their eye after the day one, after their first night of wear, is really, really critical. And you want to see what their eye looks like. Now, in the past, we've seen people on various schedules, sometimes 1 day, 1 week, or a month. Some of those can be tried to be scheduled as phone or televisits. So basically the visual acuity, you can send them home with a chart and have them monitor their acuity. But again, you have to establish when it is critical that they come into the office for you to see them, and make sure they're familiar with your office procedures and how they have to prepare for that office visit. So again, that involves equipping your equipment with the PPE and your own protective equipment. But relative to Ortho-K, there are some special procedures that you should take into account for the patient safety, and that's especially if you're using any diagnostic lenses. Again, you have to have a special sterilization procedure. Any lens removers or applicators probably are not able to be reused or shouldn't be reused. But again, that is one advantage. Here we're talking tonight with Euclid. Euclid provides a system of empirical fitting. So I'll just leave it at that for now. But again, after you've gone over this, reassure the patient that it's safe to visit your office. Proceeding with Ortho-K is safe. talk about the importance of hand washing and emphasize the lens care compliance. That's critical to their long-term success and their long-term safety. But I talked about the advantages of Ortho-K before, but the number one advantage initially, the short-term immediate advantage, is they don't have to wear correction during all their daily activities while they're awake. It's also shown that kids, when they don't have to wear glasses, are more self-confident. They experience less symptoms than soft lens wearers. They feel that they actually see better with no correction on their eyes than they do when they are wearing their glasses, when they wore their glasses. And patients feel that they look better. So these are advantages, but there are a couple more. Less activity restrictions. They don't have to worry about being functional if they're around water sports. And of course, these days, no fogging of glasses with the face mask. So it's a potential advantage of Ortho-K there. Presenting the disadvantages of Ortho-K, being objective, you have to tell them it does require that you wear your lenses on a very consistent basis. You're going to prescribe a number of hours each night, 7, 8, 9 hours, and that this is going to require very careful lens care and that they can't slack off on that. It's going to require a number of follow-up visits that you've already described to them, and that it may have a little bit higher initial cost. But again, as you present the advantages of this, I think it'll become apparent that Ortho-K and managing their myopia is important. The opportunities, like I started off saying, as you go back to school, is a chance to educate patients all about the things that we have learned about myopia, the management of that, the monitoring the axial length growth, and the treatment options, especially Ortho-K, and again, possibly other eye health issues long-term, and the importance of eye hygiene, washing their hands, and the contact lens care. But you can establish, by doing this, educating them about all these new procedures gives you the position of authority and of being able to say, I care about you. And that forges a very strong relationship with your patients and parents that will last many years. And I will say any of these types of things, but especially Ortho-K, any myopia management issue and treatment that you are providing is very exciting to the patients to learn about. A lot of parents say, I wish I knew about this before, and they're going to tell a lot of other people. And I will say in my years of practice that Ortho-K was by far the best word of mouth referral source. People tell other people about it. Now, remember that you are trying to communicate something with patients. This is something that I just have to mention really quickly, but there are 4 types of communication. You get the verbal auditory, that is your spoken word. You get visual, you show pictures of things. There's some non-visual, non-verbal type communication that you express through your body language and your facial expressions. And then there's written communication, the text. Now, in the age of COVID, you're behind a mask. Some of your words that you're speaking are a little bit muffled. It may not be totally clear. You give them pictures, you can tell them a story about what myopia means and show them graphically about the axial length growth. But this nonverbal communication basically is gone. Behind the mask, they can't see your excitement, and you have to express it as much as possible. So at the loss of that, I think you must provide written communications to the patient and be able to tell them and reinforce what you have said on paper. So I think you have to develop a very professional and very organized information folder for them. And in this information folder, you should include the answers to commonly asked questions about Ortho-K, myopia management, a summary in layman's terms on some of the studies on safety and efficacy of these treatments, and the summary of the long-term risks of myopia. There are a number of studies on myopia management and how beneficial it is and how effective it is. But again, your informed consent you could put in there. Also links to websites about myopia and myopia progression. There are links to videos that relate to this that you can screen and make sure you're sending them to sites that are reinforcing what you're saying. And again, the section, as I mentioned before, about what to do if. And I think you have to make it real for patients. In these, you might tell stories of previous patients, testimonials, things like that, examples of how these lenses have helped other people. And it has to be written at a level that they can understand and relate to. And again, some parents are highly educated, and they're going to want the citations of the studies so they can read them themselves, and that's great. But I think if you read through all of these and summarize them, it's coming and it's looking a lot more credible. So I guess as to summarize some of these things, you have to take the opportunity now that you can educate about what myopia means, how the risks may affect these kids long term, how the quality of life issues play into their immediate benefits, the education, the story of myopia progression, educate on the difference between the management of myopia and the correction. Make that distinction. Start monitoring axial length. If you're going to talk about myopia, this is the risk factor. When people have longer axial length, that's where the risks come into play. So it's an important finding, and you've never done it before, and they may have never had it done before. So discuss the advantages of Ortho-K, and then certainly reassure patients about safety and studies. And this is not a new procedure, even though they haven't heard about it. This has been going on for some time. But again, stress that this compliance issues are so important. Another opportunity for Ortho-K, I love these pictures, but it's not just for kids. We think about Ortho-K as just myopia management, but it is an alternative correcting device for myopia for those of people who don't want to wear glasses or who have issues with wearing soft lenses like dryness and other symptoms. So as you're presenting this to the parents, they may be candidates as well. So don't just focus on the kids. Keep your mind open for the possibility that the parents may enjoy not having to wear correction as well. So essentially, this is summarizing what I just said before, is that Ortho-K fits into the picture that you can provide a means to have them uncorrected during all their waking hours. You create a person who's more self-confident. They don't have to wear glasses. They're less concerned about their eyes. They are concerned about changes that will happen later in life. They have less symptoms than soft lens wearers, and they feel that they see better than when they had their glasses on. They feel they look better. And to boot, all of these advantages, plus it slows the progression of myopia. So don't forget the opportunity that you have to connect with patients by telling the story of myopia, what we have learned about myopia and progression and the long-term risks that it creates for our patients. You have the ability here to educate your patients on that progression and really what you can do about it and the short and long-term benefits of Ortho-K, but as well the other alternatives if they're not candidates or they're not able to do Ortho-K, include the soft lenses and pharmaceutical intervention. This is a slide that I want to put up before you ask questions, because invariably in the United States anyways, people always ask this question: aren't you prescribing Ortho-K for myopia management? Isn't that unapproved? Well, we're prescribing it in a fashion that's called off-label, and that's to use a product that is approved for one thing, but you're prescribing it for a different purpose. And that happens probably every day in your practice, where you prescribe an antibiotic that's indicated for conjunctivitis, but they have a corneal infection. Or every other myopic management treatment are also being prescribed off-label. Ortho-K, for example, is prescribed and approved for correcting myopia, but not for slowing it. bifocal and multifocal soft lenses are approved for presbyopia, but the only one approved for myopia progression treatment is the MiSight now. So if you prescribe any of the other lenses for that, that's an off-label application as well. Same thing goes for atropine. Yeah, it's approved for dilation and cycloplegia, but not for slowing myopia progression. And again, single vision spectacles are there, and they're approved just for correcting refractive error. So the important message here is that you can prescribe off-label. Don't avoid it. You've got a carefully explained and evidence-based treatment modality that you are prescribing for them and that you believe in, but just get the documentation that you are using this, if you're using it for myopia management, in an off-label fashion as part of your treatment. Now, I think that's about it. I hope we have time for questions. I just want to leave you with one thing relative to the opportunity that says these are challenging times, but they're filled with opportunity. And this was from Robert Kennedy. So thank you for attending. Thanks for your attention. And I would welcome any questions now. And Jane, if you have some written in, please
I
share
do.
those.
Thank you very much, Dr. Lipson. You know, you hit on some great points there, Michael. And I did want to mention, we've got 8 or 9 questions I want to get to there. I thought, you know, some of the things you touched on really made a difference to me. Like, you know, in our practice as practitioners, we're not limited by study protocols. And you're exactly right. You know, study protocols are written a certain way and you can't go outside of those protocols. But that doesn't mean we can't fit those patients. You know, we
Exactly.
all know that Ortho-K approval as far as a refractive cylinder is up to a minus 150 with the rule. Minus 75 against the rule. That's what the protocols say. That's where they've been studied to be safe and effective. But surely, if you've got a patient with a 175 or a 2, as you showed in your example, that would be well within the acceptable range. So I love the fact that you brought that point up. I do have one question for you before we get to
Okay.
everybody else's question. I'm going to do mine first. Any indication, you mentioned washing your hands several times, and I talk to my patients all the time about wash with soap and water, rinse them good, wash them with soap and water, rinse them good. What's your feeling on hand sanitizers? They kind of became the darling of the world this year, as everybody thought it was easier than soap and water. Any thought about hand sanitizers?
I would say hand sanitizers are good. I would use them first and then wash your hands afterwards. The sanitizer works to kill bugs, and essentially, if any of it is left on your hands, if it's alcohol based, is not necessarily good to go in your eye. So I would say there's a little bit of caution in that. If you're going to use the hand sanitizer alone, I would say be sure they're 100% dry. But my feeling is that if you want to use sanitizer to cleanse your hands and kill any bugs on there, and then wash your hands afterwards and rinse that off, that would be my recommendation.
Yeah, I've heard a lot of concerns about, you know, not only alcohol, but lanolin, cocoa butter, so many of the additives that they put into lotions and sanitizers to soften the skin, but they're not good things we want on our lenses on a general basis.
Exactly.
Yeah, just as we've always taught our GP patients to
Yep.
wash their hands and to stay away from additives. You also mentioned age for children, and I was going to reinforce that too. There are some strict age limits in certain governments. I know in mainland China, they are not to fit children under the age of 8 years old. Here in the US, there is no approval that includes age. It's up to the doctor's recommendation. So depending on where you practice in the world, check for your governmental direction on the age limits for children. Let's see, we've got a bunch of questions here. David said, if 50% of the world's population, it will be myopic by 2050, which is we've heard from the Holden group.
Yep.
Shouldn't the risk of myopia be at least 50% for every child, regardless of risk factors? I think
Well,
that went back to your slide about the
there, there,
25%. Yeah,
there was a slide that if no parents were myopic,
yeah.
that about 25% of those will become myopic.
Hmm.
Um, I don't know. I guess you'd have to crunch a lot of numbers to make that come out right, but this is just a projection. And hopefully, I guess if you read these projections, that's based on the current trends. If we are able to initiate myopia management in a significant way, we may be able to reduce those numbers long term and not
Exactly.
make it 50%.
We
So,
we hope by the time we get to 2050, it's not nearly as high as what the Holden projections currently show,
right.
and the World Health Organization. It's certainly every one of our jobs is to reduce that number and to get ahead of this curve as much as we can. Um, Sharon had asked, is a cycloplegic refraction, do you need to do that every year if the patient is already on an Ortho-K regimen? And if so, is 1% tropicamide sufficient?
That's a great question, Sharon. Thank you for asking that. Um, I have, to be honest with you, again, I have not done that each year. Okay. I like it for baseline because you know where you're starting. But oftentimes, when somebody is undergoing Ortho-K, you're going to be able to evaluate their progress or changes in their refraction based on their acuity, based on an over refraction over the lenses, and axial length. I think axial length is really the key thing that you're trying to slow. So I would emphasize that part of it. Um, and the refraction that you get each year isn't always a solid endpoint refraction. And many Ortho-K practitioners have found this, that it's not going to be as precise as your baseline refraction. So I would say no, the cycloplegic refraction is not critical on an annual basis. But for baseline, it should be done.
Yeah, do it before you get started. I say do anything you can possibly do prior to ever putting that first lens or that first drop. I don't care if it's atropine or if it's a soft lens or a rigid. Before you begin to intervene, make sure you have your baseline data solid.
But
You
if
know,
you, and to get to the last part of her question,
hmm.
if you really choose to do that, um, tropicamide will work if you do it in multi doses, not just one shot. You know, do it 2 or 3 times with 5 minutes in between.
Great. Um, Here's another one. How about this one's from Joyce? Any suggestions for instrumentation to measure axial length? In fact, I saw that pop up, and I think Sharon also asked that. And I get that question a lot, Mike, because, you know, if you're looking at an IOL master, it
Mhm.
may not be in the financial plan for most optometric practices.
Well,
Do you know of other
obviously,
equipment out there?
I'm pretty intimately aware of the options out there. Yes, I think it's been proven the most accurate is the IOL Master or the Lens Star.
Mhm.
Those are both quite pricey pieces of equipment. There are some new devices that are being developed, and not in the United States at this point. I think they're in Europe. A couple manufacturers are coming out with a device to do multiple functions, refraction, axial length, keratometry, all in one. So these have been proven pretty good also. But I happened to do a study on an ultrasound device years ago before we got our Lens Star, and it was one that was an ultrasound handheld by Micro Medical Devices called a Palm Scan, and the ultrasound devices are very touchy from the standpoint that you're actually having to contact the cornea. Uh, Personally, I did a study on it to try to correlate that with an IOL master, and it correlated pretty well, but it did consistently show slightly lower numbers. Now, I guess the biggest factor on these is that they are operator dependent. So if you are the only one doing this, I think you can get consistent findings from one reading to the next, meaning you're trying to monitor change. It's not an absolutely accurate finding, but compared to what your baseline was, if you use the same device with the same operator, I think you can use that for charting changes. So I hope that answers the question.
Mm-hmm. Yeah, I've seen a couple of those pieces of equipment you've mentioned. Some of them are going to come in at, you know, a very reasonable price, I think, to start adding on to the optometric practice.
That is going to come in the future, but if you want to do something immediately,
Mm-hmm.
those are the options, and you can find used pieces of equipment like those too.
Yeah, we have a couple of questions up here about fees, and I'm going to say the same thing I say every time we do a webinar. We're not allowed legally to discuss any kind of fee or management programs. You know, as far as numbers go, if Dr. Lipson, do you want to make any did you charge for the lenses and then every follow-up visit? Did you do a global fee for the first year? How did you do it at the university?
We did a global fee for the first 6 months of care.
Okay.
And we had to figure the number of likely visits and charge appropriately for those. And I think charge for your services. That's the best thing I can tell you. And again, if we need to talk more on an individual basis, I think you can arrange that, Jane.
Mm-hmm. Absolutely. Larry also brought up, and I think this is an important point, at the University of Rochester, where I was for a long time in a private practice, those global fees was for myopia management. Now, what that meant to my patient, if I started with ORTHO-K and their child could not adapt for some reason, or perhaps I wouldn't, and we needed to move to atropine or a combo, or I needed to move to a soft lens or some kind of something, then that was all covered in that. I didn't charge them over and over and over again. I kind of think that's kind of the way it works for most of the universities. You know, you can
I've talked
switch
to
from
a
one
few
to the
people
other.
in private practice as well, and they have also encouraged that same kind of a style where to monitor patients on a regular basis, whether it be every 2 months, every 3 months,
Mm-hmm.
6 months, whatever, that they established a fee for managing that myopia that is different than what it would be just for a standard office visit or soft lens fitting, things like that.
There's another question here that a doctor asked about experience with higher RX ORTHO-K. I'm going to have to say again, I want to remind everybody that there is an approval limit set by every government that restricts this kind of thing. So for every individual product. So Mike, if you want to make a comment about what you personally did, but I do want to recommend that there are government limits to the amount of prescription.
I will say the same thing I said before about off-label. If you're going to prescribe above what is approved, that's an off-label application. Some people who are very experienced may be able to have quite good success with that. But I think it's taking a risk, and you have to, based on your experience, decide what you are comfortable doing and what you are comfortable describing to your patient, and how you're going to deal with that if, for example, you don't get a full correction. That gets to be very complex at that point.
Mm-hmm.
If you've got somebody who is higher than an approved amount and they don't get a full correction, how are you going to deal with that issue if they're walking around with 20/40 vision as opposed to 20/20? It gets to be a lot more complex.
It does, but I will say, as somebody who's done a lot of studies on higher myopic corrections, fitting a higher myope and getting good refraction. You can't expect a -9 to behave the way your -3 patients do. So sometimes it's actually easier to put them in partial correction and give them some part-time glasses than it is honestly to try to fit. The fitting and response of corneas in very high minus is not consistent with lower minus. So I always caution people, don't think you can fit that -12 like you did that -3, because the chances are dropouts are much higher, returns are much higher, and best corrected vision is usually lower. So it's kind of a mixed bag for sure. Okay, so Dr. Lipson, we've been talking about off-label, or you've been talking about off-label, I haven't. But I'm going to read you this question just as it is, because I think a lot of people ask it. It says, Suko says, quote, off-label, unquote, means an illegal action. Am I wrong?
You are wrong. It is not illegal. It's done every single day in the medical field, in our field, that drugs are prescribed for various purposes that they are not approved for or indicated for. And like I said, the easiest example in eye care is antibiotics that are prescribed. They're approved for one indication only. And we have just come to prescribe them because they work well for other things too, even though they don't have that indication. One of the things that, I don't know, again, in our field that developed recently because of an off-label application was Latisse. And something like that, when people were using glaucoma medications, it made their eyelashes darker and longer and thicker. And so essentially it was used like that for a while until it actually became approved in that other format. So I think that still could happen with Ortho-K one day in our dreams, that it would get FDA indication for myopia management. But
yeah, I always say one of the most common things utilized today in cardiac is the use of low dose aspirin. Many of us of a certain age take a daily dose of aspirin. Well, aspirin is approved only as a painkiller, but that's not why your doctor tells you to take it. So that's probably the widest use of an off-label product. So, with Dr. Lipson, I always say practitioners have leadway to prescribe as long as the product has been proven safe for some, that's a big part of it. You can't just start using anything, but if it's a safe, approved product for something and you're going to use it for something else, that's where you get into off-label.
but it's definitely not illegal.
Correct.
And I guess I would just emphasize, going back to that informed consent, that you're making patients aware of what you are doing and why you're doing it and the justification for doing it.
Yeah, somebody just popped up and said, if off-label is illegal, every compounding pharmacy would need to shut down, because that's what they're doing. So there's a good point. Okay, so enough about that. Let's get to a couple of important questions here before we close it out. Let's see, Fani Krishna would say, how long should you wait after discontinuing Ortho-K to do LASIK? That seems to vary quite a bit through the top surgeons, but what did you tell people at the university, Mike?
I told patients that they should count on 3 to 6 months, no less than 3 months, and basically qualified that with, we want to see stable topography readings in addition to stable refraction. Now, there are people who will argue that you will never have a return to baseline, a total return to baseline, but that's still debatable as far as I'm concerned. But I would say a minimum of 3 months, and then I told most people, just to be safe, go 6.
Yeah, I've heard surgeons tell us 12 months. I've heard very conservative surgeons tell them 2 years. It seems to be all over the board, but I do think if you can show a pattern of a couple of stable refractions and stable topographies, most of the good LASIK surgeons will take it and run. Bonnie also asked, could you give us any crucial tips to really make them pick to go with myopia control where there's cost involved? It's probably more expensive than just getting a pair of glasses. You know, I think you covered a lot of that, but any other tips that you think you could throw that way?
Well, like I said, I try to frame all of this in the benefits and risks to the patient, long-term and short-term. And I really feel strongly that the benefits, the immediate benefits of Ortho-K relative to quality of life issues are really, really important. The kids who are going through this comment on this all the time. God, I feel so much better not having to wear glasses. I can do more activities. So that short term is what the kids feel.
Mm-hmm.
And the parents can feel good that they are reducing the risk of their kids having problems later in their life. So I think it's a no-brainer to me. But again, the more people do this and the more people say this is a great treatment, they share that excitement with their friends. And so I got to a point in the practice where people came into the office and begged me to fit them with Ortho-K. I didn't have to mention it to them.
Yeah. Okay, a couple of quick final questions, and then I'm going to wrap it up. So how about binocular disorders with Ortho-K? Do you incorporate that into it?
Well, I would say that's a little tricky. That would have to be done on a pretty much an individual basis. But I think there is a potential that, especially for kids who are esophoric, and they are looking through their glasses up close, they're having to converge more, and things. So it actually could be better from that standpoint. That they would get an advantage in going from -3 to plano, that they would have to accommodate less, and it could actually reduce their esophoric posture.
Okay. Any thoughts on post-refractive surgery cases with Ortho-K?
I have a lot of thoughts on it.
Any you can share, Dr. Lipson?
I would not advise this for a new practitioner, someone who is highly experienced with this. It's still a challenge. It's always a challenge because they don't go as predicted. It's a very highly individual case, and we've had some very good ones who were just not candidates for enhancement and who were very moderately, had moderate nearsightedness as a residual correction. It can be done, and you can't use your traditional methods of fitting. You have to use some specialized techniques.
Wonderful. Listen, there's no way we can get to all these questions, and they're all excellent. I just saw that the team has popped up Dr. Lipson's email if you want to communicate with him directly. If you would like to communicate with our staff at Euclid, David Bland heads up our sales group, and his email is up on the screen now. I also want to tell you, we thank you for your personal attendance tonight and your wonderful questions. You stuck with us to the end, and I know it's a late day for many of us, or a very early day for some of you. This, as all of our webinars, has been recorded tonight, and you will be able to find it on YouTube probably by the end of this week. So again, if you check about Friday, you'll be able to listen through it again, or recommend it to any of the other practitioners, students, or patients, well, not patients, but students, or other practitioners or staff in your office. So on behalf of Euclid Systems Corporation, Dr. Lipson, thank you. It was a wonderful and informative program tonight. And for all of you who have joined us around the world, on behalf of Euclid, we thank you for your time and your attention. Have a good day.
Good night, everybody.